You can hear me, right?
Yes, yes.
Hello, Jyotipriya madam. This is
Hi.
Radha. How are you?
I'm fine. I'm fine. One second. I'm just trying to hide my background.
Ma'am, we are live now.
Yeah, you can start.
So good evening, everyone. And I welcome you all to another insightful session hosted by Nephrocon team, an academic initiative for nephropathologists powered by Cognos Life Sciences. Today's session follows our usual format, which is like a 1 hour webinar. The first 20 minutes will feature a renal pathology case presented by a nepropathologist, followed by a 40-minute panel discussion with nephrologists and clinicians. Our topic today is non-diabetic kidney disease. While diabetic mellitus has puzzled us for decades, its rising prevalence has been accompanied by a growing number of non-diabetic kidney cases as well. Differentiating DKD from NDKD and identifying it early is not just an academic challenge. I think it's a challenge. It is essential for effective and personalized patient care as well. Ultimately, our shared goal is to preserve renal function. To lead today's pathology discussion, we are delighted to welcome Dr. Radhika Patil ma'am back. She is director and consultant nephropathologist at the Sri Balaji Diagnostics at Hyderabad, and also vice president at Basic Sciences at ISOT, and also the author of Renal Pathology Express. I welcome you, ma'am, and it's an absolute pleasure to have you with us again. And I will hand over the stage to you now for your scientific talk.
Thank you. Thank you, Seema ji.
Mosambia.
Ma'am, you can share your presentation. I will stop sharing.
Yeah, thank you, Seema ji. Thank you, Nephrocon and Dr. Purva Babikar madam and Cognos for giving us this opportunity. Respected panelists, Dr. Christine madam and Dr. Jyotipriya madam, and dear all, today's talk will be on non-diabetic kidney disease in diabetics. So not all that glitters is glucose. Diabetes is the commonest cause of CKD worldwide. 30% diabetics develop CKD in their lifetime. 2/3 diabetics with renal involvement have either a completely non-diabetic or coexisting NDRD. NDRD, that
I'm
is
sorry
non
to interrupt. We are not able to see your slides.
Oh, so sorry. I'm so sorry.
Yes.
Can I start now?
Yes, yes.
Just move this. Yeah. So yes, so respected panelists, Dr. Christine madam and Dr. Jyotipriya madam, Dr. Purva Babikar madam and whole Nephrocon team, Seema ji from Cognos, I would like to thank you for giving me this opportunity. Today's talk will be on non-diabetic renal disease in diabetics. So not all that glitters is glucose. Diabetes is the commonest cause of CKD worldwide. 30% diabetics develop CKD in their lifetime. 2/3 diabetics with renal involvement have either a completely non-diabetic or coexisting NDRD. So non-diabetic kidney disease or renal disease is most accurately diagnosed using kidney biopsy. So what are the clinical pointers to suspect NDRD in diabetics? When we see nephrotic syndrome or sudden appearance of proteinuria, active urinary sediments, rapid deterioration of renal functions, rapid decline in GFR. eGFR declines by approximately 1 ml per minute per year after the third decade of life. An annual decline of eGFR by more than 10 ml per minute per year in diabetic should raise the suspicion of NDKD. Renal dysfunction without significant proteinuria in a diabetic patient should raise the suspicion of renal artery stenosis. Also, their absence of diabetic retinopathy and short duration of diabetes mellitus, that is if it is less than 5 years. So what is the correlation of diabetic retinopathy with nephropathy? 60% of type 2 diabetics with retinopathy have a coexisting nephropathy, and 100% type 1 diabetics with retinopathy have nephropathy. 40% type 2 diabetics with diabetic nephropathy do not have retinopathy. Presence of retinopathy, although hints towards a DKD, but cannot conclusively rule out a non-diabetic kidney disease. So this is one of the studies from Maharashtra, which states that the shorter duration of diabetes and absence of retinopathy, especially when associated with nephrotic range proteinuria, strongly predict NDRD. Another study from IPGMER, in which subjects with non-diabetic kidney disease as compared with diabetic kidney disease had shorter duration of diabetes, absence of retinopathy, and absence of neuropathy. 30% of diabetic kidney disease did not have retinopathy in their study. So confirming a non-diabetic renal disease, why does it matter? Firstly, NDRD is often treatable and reversible. Secondly, misdiagnosis can delay appropriate treatment and lead to progressive CKD. Finally, early diagnosis improves the outcomes. So what are the different NDRD if we classify like glomerular diseases and non-glomerular diseases? In glomerular diseases, according to presentation, nephritic syndrome, IgA nephropathy, and infection-related GN, nephrotic syndrome, membranous nephropathy, minimal change disease, and focal segmental glomerulosclerosis, RPRF, like pauci-immune glomerulonephritis, and SLE. Non-glomerular diseases, in case of AKI, ATN, that is acute tubular injury or acute tubulointerstitial nephritis, UTIs, ischemic nephropathy, and obstructive uropathy. So to understand this, let's have some real-life case scenarios. Case first is 60-year-old male, diabetic for 10 years, hypertensive for last 4 years, controlled on a single drug. He is non-smoker, non-alcoholic, not on any indigenous medication or NSAIDs. He presented with progressive edema, fit, and facial puffiness for last 1 month. He has been feeling short of breath on routine daily activities. He has no lower urinary tract symptoms, no other symptoms like rash, oral ulcers, arthritis, uveitis, or hemoptysis. He has been feeling lightheaded and giddy on standing, and his physician had increased the dose of his diuretic and stopped his BP medication in previous visit due to a lower BP of 100 by 60 millimeter of mercury. On routine investigations, hemoglobin was less, he was anemic, all other counts were within normal limits. HbA1c is raised to 8.4%. Serum creatinine is slightly raised to 1.6 milligrams per DL. Serum albumin is low. Total cholesterol is high. So basically it is nephrotic syndrome. Urine protein 4+, RBCs were 3 to 4 per high power field, pus cells 1 to 2 per HPF. Urine ACR is 200 and urine PCR is 5 grams per gram. So there is disassociation between these two. His fundus examination revealed early diabetic retinopathy. USG shows bilateral normal size kidney with maintained CMD. So our clinical diagnosis was nephrotic syndrome with mild renal dysfunction without any systemic signs of connective tissue disease, but there was diabetic retinopathy. So what are the pointers towards DKD and NDKD in our case? Towards diabetic kidney disease, there was long-standing diabetes, presence of diabetic retinopathy, absence of systemic signs of any other connective tissue disease. And towards NDKD, patient was hypertensive, but there is new onset drop in BP without obvious cause and nephrotic range proteinuria with relatively low albuminuria. So the biopsy was done, and yes, this is H&E stain showing you may see that there is nothing to be seen, but actually this is very pale, waxy deposits in the mesangium and forming a cellular nodules. There is no increase in cellularity or basement membrane thickening or crescents, which is later on seen on PAS as PAS negative mesangial widening. And here on the left-hand side, if we see, this is a case of diabetic kidney disease, in which this here we appreciate this is afferent arteriole and this is efferent. Both are showing intimal hyalinosis, and there is presence of this KW lesion, which is seen as diffuse, like the KW nodule, Kimmelstein-Winzel nodule is formed, and there is thickening of the GBM. So this is all PAS positive. If you can see the GBM and the Bowman capsule color, that is PAS magenta color positive. And here also, if we see, this is a case of diabetic nephropathy, and this is a case that we are seeing now, which is PAS negative material in the mesangium. Why it is PS negative? Look at the basement membrane, tubular basement membrane, and the Bowman capsule, and even the GBM, that is PS positive. So this material is waxy, pale, eosinophilic on HND, PS negative on PS stain, and silver negative, and bluish on meson trichrome stain. So this was congophilic and showing apple green birefringence under the polarized microscope. On immunofluorescence, it was kappa was negative. All other immune deposits were immunoglobulins and complements were also negative. Kappa negative, and lambda was strongly positive. So it was lambda restricted amyloid light chain, AL amyloidosis, lambda light chain restricted. Additional investigation showed monoclonal M band, and free light chain assay showed lambda light chains elevated. Beta 2 microglobulin levels also elevated, and bone marrow biopsy showed 20% of the plasma cells. So these are few pathology pearls taken from my book, Renal Pathology Express, that even on light microscopy with the help of the spatial stains, we are able to differentiate this nodular glomerulosclerosis. So in idiopathic nodular glomerulosclerosis, which is seen in hypertensives and the smokers, that is ING, and both are showing this PS positive mesangial nodules. But in amyloidosis, it will be PS negative, except in case of amyloid high chain, that is AH amyloidosis, it can be PS positive. So it will be congophilic, and both all other entities will not be congophilic. But fibrillary, nowadays they say that it can be congophilic. So I'll not go into details, but fibrillary DNA jebinine is there to save us. And fibronectin, it will be fusionophilic mesangial widening, that is reddish, and collagenofibrotic on empty, and collagenofibrotic glomerulopathy will show bluish mesangial nodules on meson trichrome. So another thing, that how to differentiate diabetic nephropathy from MPGN, light microscopically. In diabetic nephropathy, all the glomeruli may not be uniformly affected, but in MPGN, all the glomeruli will be uniformly affected, and there will be marked mesangial hypercellularity in MPGN, and also there will be double contouring, tram track appearance, and mesangial cell interposition in membranoproliferative glomerulonephritis. One more thing, in diabetic nephropathy and MIDD or LCDD, that is monoclonal immunoglobulin deposition disease or light chain deposition disease. So to the nodules, what we have seen now in diabetic nephropathy, they can be asymmetrical, but in MIDD, they will be symmetrical. And also they will show silver stain, weak positivity or negativity in MIDD. IF study light chain restriction, as the name suggests, it will show, but sometimes even diabetic patients will show the same IF pattern, that linear staining. So IF albumin will differentiate. It will be positive in diabetes. And EM study will show the Randall type deposits. Those are the granular punctate powdery electron dense deposits, which are seen on the inner side of the GBM and outer side of the TBM. So now coming to case 2, this is 40-year-old male, diabetic and hypertensive since for 5 years. He came with generalized swelling of whole body, abrupt onset, which is abrupt onset, and since 2 months, no urinary complaints, no fever. There is no history of skin rash, oral ulcers, or arthralgia, and urine analysis showed protein 4+. Microscopic hematuria was there. 24-hour urine protein was high, 14 grams. Serum creatinine normal, and there was low albumin. So clinical diagnosis was adult onset nephrotic syndrome with microscopic hematuria without renal dysfunction. So the differential diagnoses were membranous nephropathy, then MCD or FSGS. So the renal biopsy was done, and it was showing diffuse uniform thickening and rigidity of the basement membranes. So this glomerular basement membrane thickening is generally lesser than the tubular basement membrane. So we have to compare with the tubular basement membrane. So, and it is showing the diffuse subepithelial spikes on the silver stain. And this is 100x. So that is oil immersion. We can see beautifully here the subepithelial spikes. Also on the mesenteric, which is known as poor man's EM, the fusionophilic subepithelial deposits on the mesenteric. The IF was showing IgG showing the diffuse granular, fine granular positivity along the capillary wall. When we did PLA2R IHC, it was showing anti-PLA2R IHC, and it is showing the overexpression along the capillary walls with the granular pattern. So this was a case of anti-PLA2R mediated membranous nephropathy. Now one more case, case 3, 56-year-old male, diabetic and hypertensive for 15 years, presented with progressive edema feet and decreasing urine output along with shortness of breath on exertion for last 1 week. There is a history of diabetic foot ulcer infection 1 month back, which is now better. He has no fever or active infection at present. BP is high, 170/100 millimeters of mercury. He has diminished sensations in both feet since last 1 year. He has diabetic retinopathy, related treatment done in both eyes. So no other history significant of medicine usage. Investigations showed urine analysis protein 4+, microscopic hematuria, urine UPCR is 6 grams per gram. Serum creatinine is raised to 6 milligrams per deciliter. Previous serum creatinine 6 months back was 1.5 milligrams per deciliter. USG KUB showing normal size prostate and no void residue, post-void residue, no hydroureteronephrosis. So clinical diagnosis was AKI with nephrotic range proteinuria, and DD was diabetic nephropathy and PIGN. So this is the renal biopsy showing HND stain, and we can appreciate here the glomeruli are enlarged and hypercellular. When we see enlarged, meaning they are more than 2.5 size of the proximal convoluted tubule, and they are exceeding the 40x field of vision under the microscope. So here we appreciate this green arrow is showing this diffuse mesangial and endocapillary hypercellularity, obliterating the capillary lumina with this neutrophils. They are showing this attenuated trilobed nuclei, and there is mesangial widening, which is PS positive and silver positive mesangial widening. So this is a case of nodular diabetic nephropathy with PIGN, and on MT also we can appreciate this mesangial widening bluish. On IF, IgG immunoglobulin was seen along the capillary wall and in the mesangium also as coarse granular deposits, and IgA was also present. So C3C was showing this classical starry sky pattern. So this was a case of diffuse proliferative glomerular nephritis exudative pattern with diabetic nephropathy and IgA co-deposition in the capillary loops, and IgA co-dominant PIGN can be considered, which is commonly associated with staphylococcal infection associated GN, and there are background changes of diabetic nephropathy. Now I'll document certain case reports. So from different institutes in wherever the studies are done, these all are the retrospective observational studies in which the biopsies were done in the diabetics. So this is a study from SGPGI Lucknow, in which the 538 patients whose biopsies, who were diagnosed as diabetes, and their biopsies were seen over the 17 years of study, over the 17 years of duration. And we have seen that the NDKD population was 49% were showing NDKD, and the most common was acute tubulointerstitial nephritis. So other study from South India, in which we have noticed that NDKD was present in 18% of the 236 patients over the 5 years duration study period. And the most common was again acute tubulointerstitial nephritis, the NDKD. From the current study, the long duration of diabetes mellitus, that is more than 5 years, and hypertension more than 2 years reasonably predict the diabetic kidney disease. So one more study from Arcana Laboratory. They have studied 6 biopsies of 620 diabetic patients over a period of a year. And 36% non-diabetic renal disease were seen, and the most common was acute tubular injury. So another study from Yashoda Hospital and Apollo Hospital, where over a period of 3 years, all the records of 1029 diabetic biopsies were seen, and most common histological lesion was isolated non-diabetic renal disease group. All are I have made 3 groups like diabetic kidney disease, non-diabetic kidney disease, and both diabetic kidney disease, the NDKD superimposed on DKD. So I'm just documenting here the importance of NDKD. That's why I have encircled the NDKD percentage. So 46.8% of this group were showing the non-diabetic kidney disease, and the commonest was interstitial nephritis, acute or chronic. And one more recent study from Tamil Nadu. So in which 60 out of they have studied 115 cases, and 60% were male, 40% were female over the period of 5 years, in which NDKD was 38.3%, and most common was membranous nephropathy. Diabetic kidney disease was more seen in males, and NDKD was more found in females. So another study from Dr. Bansal sir from Medanta, in which 130 patients over the duration of 9 years, their biopsies were studied, and all are retrospective studies. And NDKD was seen in 60.79%, and the most common was membranous nephropathy. Diabetic retinopathy was more common in those with DKD than NDKD. So here the correlation is seen again. So my own data is, I couldn't take out the data for 4 years, but I could take out data for 4 months. And out of 420 biopsies, 83 were diabetic and 28% were NDKD, and the most common was membranous nephropathy. So the treatment of non-diabetic kidney disease, NDKD, differs from diabetic kidney disease, and the timely diagnosis of non-diabetic renal disease is of great importance for early etiological treatment of patients, which can significantly slow down or completely stop the progression of chronic kidney disease to the end stage renal failure. You all know that, being a nephrologist. So thank you. I hope I stick to the time.
Thank you, ma'am. Yeah, actually, you covered quite a lot. So you've done half of my job to, proceed further. And it's interesting. I have one question for you after your this thing. There are in your 4 months
Yes, ma'am.
this thing, there are 56 cases where the diabetic nephropathy was this thing. So my question is, are people like are nephrologists in Hyderabad or those samples which you are receiving, are they doing biopsies for probably suspected diabetic nephropathy cases also?
Yes, yes. So whenever there is AKI in diabetic, then they are doing this.
Okay.
Otherwise, for diabetic, not much cases. When there is suspicion of NDRD, so I will say this is restricted data, not unrestricted. For every diabetic, it is done, because I'm just documenting, because whatever history I'm receiving, according to that.
Yes. But it is like, why I'm asking is,
Yes, ma'am.
it's not, what do you call it? It's not black and white that you cannot biopsy somebody who has diabetic retinopathy or, the classic symptoms wherein a patient is fitting for diabetic nephropathy. But even if eventually we find out on biopsy that this is diabetic nephropathy, the treatment becomes a lot easier. Like initially, there was a debate where the question was, why biopsy diabetics who fit in the classic criteria of, they have a diabetic retinopathy, they have proteinuria, then don't biopsy, just treat them with, anti-diabetics, glycemic control, blood pressure control and all. But eventually now they are finding out that even non-diabetic kidney diseases are fitting in the diabetic retinopathy range.
Yes.
So as such, apart from the criteria that you have mentioned about the indications of kidney biopsy, all of them, what you have received, do they fall in the same category? Like overt proteinuria, hematuria,
Yes.
rapid decline in renal failure.
Yes, ma'am.
Okay. Okay. With that, I'll just move on to our panel discussion. It has really been interesting because honestly, now non-diabetic kidney disease, it looks plain and simple, but it is not. And just like an individual can have FSGS, IgA nephropathy, acute tubular injury, crescentic GN, all these entities, when they occur with diabetes, the whole game changes and our approach to the case changes. So
Yes,
to
even before documenting acute interstitial nephritis, we pathologists also have to think like
yes,
because even
because in
acute
that scenario, or maybe when you are giving a diagnosis of non-diabetic kidney disease, as you mentioned, immunosuppression is also given.
yes.
And somebody, let's say immunosuppression, most commonly is steroids. And
Mm-hmm.
then comes mycophenolate or even the CNIs or whatever. So if the entire treatment protocol is based on that biopsy, and if we screw up with that, there is a possibility that you will have exaggerated like uncontrolled diabetes, causing more rapid progression of the diabetic kidney disease over non-diabetic kidney disease. So coming to that, ma'am has already covered a lot, so I'll not display my slides. But in order to go ahead with the panel discussion, we have two nephrologists. This is the first time we have all women and on our panel. And I welcome Dr. Christine, who's a consultant nephrologist and transplant physician from Bangalore, and Dr. Jyoti Priya, who's from Kerala. And both are like, the reason why I would want them on this panel is because um, our generation tends to treat an individual disease slightly different than what it was being treated probably 10 to 15 or 20 years ago. So since majority of us are seeing more of these cases, I would want their opinion on the topic. So to begin with, I'll ask, my first question is to Dr. Jyoti Priya. As I mentioned already, when a kidney biopsy is indicated, when is it justified with diabetic retinopathy?
Okay. Thank you, Purva. Thank you so much. And thank you, Radhika ma'am, for that excellent presentation. So the question asked to me was like, the patient presenting, I'll give you a scenario, a clinical scenario where you are getting a patient in your OP, say for a long-standing duration of diabetes, say with diabetic retinopathy, probably fluorid changes, presenting with nephrotic syndrome. So how to approach this patient? I think that is the one which is being asked through this question. Now, see, diabetic nephropathy, the classical presentation is patient may have edema, proteinuria, condom can be huge. So how to distinguish this between diabetic kidney disease and non-diabetic kidney disease, and when to do biopsy, especially if the patient is having, our routine dictum is, if the patient is having diabetic retinopathy, we have a tendency to fit it into the diabetic kidney disease category. But that might not be the case all the time. Because just like any random individual in the general population, diabetic kidney disease patients can also have non-diabetic kidney disease. So does that mean we have to biopsy all the patients coming to our OP with nephrotic syndrome? See, we know if you do 1,000 biopsies, we can get almost around 1 in 1,000 complications. So imagine the quantum of complications we are going to create by continuously doing biopsy in all the diabetic patients. So here we have to apply certain clinical dictum, certain clinical judgment. Now, if we are getting a patient with abrupt onset of proteinuria, the abruptness in the onset of symptom, that is something which point towards the need for biopsy. Second thing, abruptness in the increase in the quantum of proteinuria. Say, for example, a patient is having a proteinuria in the range of, for example, urine ACR of 200 to 300, suddenly becomes 6,000. That is an indication for doing a biopsy. And another thing, when we are doing a biopsy also, like certain things we have to keep in our mind, a patient can have any disease starting from MCD, FSGS, membranous nephropathy. So especially diabetic kidney disease with MCD, the light microscopy picture can come just as diabetic kidney disease changes. So a good amount of clinical suspicion, and in such cases, we need to take 3 samples of this specimen, and one we have to send for glutaraldehyde in glutaraldehyde for EM, because reprocessed samples may not be bringing out the right result. So a clinical judgment should be applied in the scenario when the patient with florid diabetic retinopathy coming with nephrotic syndrome. So it is an individualized approach what we have to do.
Right. So, but like for some reason, I'm still, wanting to put this point across that I think, okay, if to give the benefit of doubt for every patient, we should, like, of course, if you don't biopsy the classic cases, but as you mentioned, this strong clinical suspicion wherein, you can biopsy somebody who has diabetic retinopathy, that just allows us and probably the patient also to not miss non-diabetic kidney disease.
Exactly, because thinking that the patient is having diabetic retinopathy, and if you're not proceeding in a case, imagine it is a case of non-diabetic kidney disease, we are just putting that kidney into a permanent
Constant
endangered
injury,
thing.
Yes.
So always we should have a suspicion of a non-diabetic kidney disease. What I do in my clinical practice when I'm getting a patient, a diabetic patient with the proteinuria or a renal failure, the first thing I will make sure I'm ruling out a non-diabetic kidney disease, because diabetic kidney disease, our treatment might be the same, but something what we can do and interfere and save the kidney is in the case of a non-diabetic one. So first approach, or first step should be somewhat we have to rule out this is not a case of a non-diabetic kidney disease.
Right. So there was one paper, I don't remember exactly, I think it was in the Frontiers. They gave a very beautiful picture wherein there's this Venn diagram wherein, you have DKD, you have NDKD. At times, you can have non-diabetic kidney disease in the background of diabetic kidney disease, and that complicates things. For example, somebody can have diabetic nephropathy, but at the same time, they may have IgA nephropathy, or they may have what ma'am mentioned, membranous nephropathy, or even, for example, monoclonal gammopathy, which also can happen to a diabetic patient. So that is this point that we are discussing more and more is please do not miss non-diabetic kidney disease. Just because you're not biopsying, you may not be able to get the finding. My second question to you is, Dr. Jyoti Priya, in case of a combined non-diabetic kidney disease and diabetic kidney disease, or plain and simple non-diabetic kidney disease progressing to diabetic kidney disease, how should a physician monitor and manage the progression to prevent worsening of kidney function?
Okay, so a combination of diabetic kidney disease and non-diabetic kidney disease, I think that is one of the deadliest combination, because you are having the risk factors of both, and when it is happening in the same kidney, the outcome is not that good. There can be a rapid progression of renal failure. So the time duration the patient can reach the end-stage renal disease or dialysis or transplantation, that is cut short when there is a combination of these two entities. So basically, we should have aggressive measures to monitor as well as to treat this type of scenario. Now, regarding monitoring, what I prefer, we have to, for example, we are getting a case of proteinuria or a renal failure. So in case of, the best thing is urine albumin creatinine ratio. And for example, a non-diabetic kidney disease, getting a relapse, there will be a significant rise in the quantum of proteinuria compared to that can happen in a normal progression of a diabetic kidney disease. So we need to have a good clinical suspicion and a constant continuous monitoring, especially the urine albumin creatinine ratio, the quantum of proteinuria. And regarding the part, how to prevent, I think we have to apply the general principle. One, regular monitoring and a constant vigilant suspicion. Second thing, we have to apply all the strategies, say for all the 3 pillars we have, that is RAS blockers, SGLT2 inhibitors, and we have to control the blood sugar, the BP management, the blood pressure control, then obesity management, weight control, and also the lifestyle changes, salt restricted diet. So everything, we have to bring a combined approach where drugs, lifestyle changes, and also a specific targeted focus on identifying the relapse of the non-diabetic kidney disease timely and managing it. So the management is little bit complicated and the combination is deadly. So we have to keep in mind there can be a possibility of rapid progression of renal failure and the proteinuria and the nephrotic picture in this type of scenario.
Right. So, just to, answer the previous question also, diabetic retinopathy may not be there while you biopsy, but there is a possibility that they may develop diabetic retinopathy later. So I think that also should be a part of monitoring, apart from proteinuria, apart from the GFR like serum creatinine. And apart from all that, we are taking care of blood pressures and all the other routine labs. But in these patients also, I think we should be looking at the fundus. They may not have it, but probably 2 years down the line, 3 years down the line, there may develop these features. What do you think about this, Dr. Jyotipriya?
Purva, just repeat your question.
My question is, when you have a patient labeled as NDKD, now you are monitoring that patient, right? We are going to do proteinuria, we are going to see his creatinine, we are going to see his blood pressures and things like that. Eventually, that patient, when you biopsy that individual, I assume that there was no diabetic retinopathy. So I think when you follow them up or when you monitor them, you should also monitor them as far as diabetic retinopathy is concerned. Does that fit?
You mean, do we have to follow?
While monitoring these cases.
You are telling whether the diabetic retinopathy can predict.
Yeah, like let's say an individual, whatever we've treated, 6 months down the line, we do a fundus examination again. And let's say that patient has started developing mild non-proliferative diabetic retinopathy. This can act as a part of the monitoring system. Because the reason why I'm specifying this is, there was a study done in Spain, wherein they followed an individual for 10 years. Almost some 800 candidates were studied. And in this, irrespective of you had NDKD or you had DKD, the patients who had diabetic retinopathy had a poor prognosis. They landed up on dialysis, or they had end-stage renal disease and even transplantation for that matter. In that category, the outcome or the prognosis was slightly poor than patients who did not have diabetic retinopathy. So that just a point wherein monitoring should include fundus on timely basis, like not just once. If you've had a fundus which shows no retinopathy, 3 months, 6 months, 2 years, 10 years down the line, that also should be included in the monitoring part, is what my point is.
Yeah, could it be due to the fact that it is showing the extensive involvement of the microvascular complication,
Yes.
which in turn can predict
Yes,
the extensive involvement
yes.
in the kidney?
Yes.
It could be that one of the reasons.
So that is how, like for clinicians, every time we cannot biopsy. So we have to have these protocols set in probably 6 months, 2 years, whatever. It is a customized protocol for each nephrologist and each patient as well. But I think you mentioned proteinuria, then you mentioned creatinine and GFR monitoring. Third thing is, I think what we miss out is the microvascular complications in the form of maybe neuropathy or retinopathy. That also should be a part of monitoring, even in NDKD.
Okay, fine.
Right. So my next question is to Dr. Kristen. Dr. Kristen?
Yes, yes, sir.
Thank you for patiently being a part of this panel discussion. So my question to you is, since ma'am has already discussed this slide, and this is our own study from India, wherein the most common lesion in NDKD is the acute interstitial nephritis or acute tubular necrosis. How do you manage these patients?
Right. So first of all, thank you, Purva, for having me here. It's an interesting pattern of discussion, I would say. And thank you so much, Radhika ma'am, for bringing in, specific clinical scenario-based histopathological discussions, which is always interesting. So yes, Purva. So this is it is not a surprise that most common finding is AIN, and I would like to recollect a recent case which we managed: an elderly gentleman with long-standing diabetes, diabetic retinopathy with pyelonephritis. He was treated outside for many weeks with multiple courses of antibiotic. The infection settled, and then he started having worsening renal function. So to begin with, creat was not normal. It was when he was found to have pyelonephritis itself, creat was around 2. During the course of treatment, it rose to up to 6.5. When the features of infection settled, he was in his 80s, obese, with all the complications of diabetes. We did a biopsy because it was post-treatment of pyelonephritis, and we found AIN, probably drug-induced. We treated with steroids, he responded, and his creatinine came down to his baseline. So this is, I think it is very commonly undiagnosed. We treat so many diabetic patients with multiple infections. Many times we don't have baseline creatinine to begin with. They come with renal dysfunction. We see worsening renal dysfunctions many times. Many situations we do not biopsy. I mean, there is hesitancy in our part also, especially elderly with multiple comorbidities. We assume it as AKI, ATN because of diabetes itself. So I think we might be missing a lot of cases of AIN, and a lot of this would respond to an early short course steroids. That is what I have seen from a couple of patients I have managed. So ATN is again very common. So a lot of cases we see in our ICUs and critically ill patients who come with diabetes, with sepsis or drug induced, developing AKI. So ATN, when we look at ATN, if we recollect, the common causes are one is of course ischemia, toxins, and sepsis. This is in the clinical scenario 3 common causes. And ATN in a diabetic becomes prolonged. They are more prone for ATN. Many times without hypotension itself, they can develop ATN. Ischemic ATNs are known in diabetic patients because they have pre-existing vascular disease, atherosclerosis, and these predisposed to ATN. Their autoregulatory mechanisms are not in place, and they even become dialysis dependent, having prolonged recovery. So management depends on specific etiology of ATN, treat the cause, and I think it is like managing any other ATN. AIN, of course, we should have a low threshold for biopsy, I would say, when things are not fitting in, especially somebody recovering from a sepsis, recovering from a ischemic insult. Persistent renal dysfunction should rule out an AIN or something we are missing out, because many patients would have taken an alternative medicine in the background, some painkillers, prolonged antibiotics. All this can lead to inflammation, which we can miss out. So I think that is about AIN and ATN. And second question, I think, is about
I'll take up that question.
Yeah.
So what is interesting in this paper, which was published by SGPGI, is that they didn't have any massive proteinuria in those cases. There was active urinary sediment, or there was azotemia, unexplained azotemia in a pre-existing diabetic. So it is kind of, ironic that when we advise biopsy for, overt proteinuria or abrupt increase in proteinuria, we biopsy those patients in diabetics. But an active urinary sediment is also as important as proteinuria is to biopsy with a very astute clinical suspicion for these cases, is what the point I would want to make with Dr. Christian's reply.
Yes, Purva. So just to add on to that, I think we see very different clinical scenarios. Like what Dr. Jyoti Priya was trying to highlight is about an abrupt onset proteinuria in a diabetic, which could be certain type of glomerular diseases. Interstitial injuries, of course, we all know they present differently. And then there is another class of rapidly progressive renal failure, or just a microscopic hematuria which persists. So it is, a lot of it is a clinical judgment, and we should have a low threshold for suspecting a non-diabetic kidney disease, as I think we all are trying to highlight. Yes.
So the next question, before I ask you this question, I would want to just give you a background. Most of the diabetics which we see, or which I have seen, usually, they're probably well built. They will have a creatinine of say 4 or 5, but somehow they will be edematous in a very short span of time. That is probably because of diastolic dysfunction. And that is how classic diabetic kidney disease patients behave. Their GFR, if you compare that with the creatinine, may not be as much, but they will land up on requiring dialysis probably because of the heart, because of heart failure, because of the vascular stiffness, or whatever be the reason of fluid overload. So this question is, do patients of non-diabetic kidney disease also behave, like, do they behave differently from diabetic kidney disease with respect to cardiac outcomes, progression of end-stage renal disease, AV fistula success rates as far as diabetic kidney disease is concerned? When you create a fistula, probably in the wrist, the chances are that, they will not develop well because of atherosclerosed vessels. So we usually assess them, and most of the diabetics will have a fistula done in the brachial or the elbow region. So in comparison to all these, is there any, do non-diabetic kidney disease patients behave any differently?
Yeah, I think from whatever my clinical experience, the non-diabetic kidney disease who do not, of course, have a coexisting diabetic kidney disease, they tend to fare better than the counterparts with diabetic kidney disease. So, patients who have AIN, CIN, or they have a glomerular disease which is adequately treated, they tend to fare better. So also their elsewhere are less pronounced as compared to somebody who has a diabetic nephropathy progressing to ESRD and dialysis. They would also have the macro and microvascular complications elsewhere progressing simultaneously. Like you rightly pointed out, the vessels, atherosclerosis in the vessels, and neuropathy, the cardiac complications, all this progress by the time a patient of diabetic nephropathy progresses to ESRD.
Right.
Versus somebody who has a non-diabetic kidney disease progressing to ESRD, they tend to fare better in terms of various parameters which you have pointed out.
Right, exactly. So I come to the next question, that is again to Dr. Jyoti Priya. Dr. Kristen has already mentioned that there is some role of steroids in non-diabetic kidney disease. So I would like to know, in what cases does steroid use become mandatory for non-diabetic kidney disease? And how does the patient's diabetic status affect treatment? Are there any successful alternatives for the same?
Okay. As we all were discussing, when we have a non-diabetic kidney disease, we do have to treat it properly, even though patient is diabetic. So steroids, in most of the cases, we may have to resort to, say if it is an MCD or FSGS, or if it is an amyloid, or if it is membranous nephropathy, we may have to take the help of steroid, or even in case of acute interstitial nephritis, as Dr. Christian was mentioning. So in these scenarios, how to start steroid treatment and how our approach should be, see, what I do is I'll take the overall picture of the patient, his or her diabetic status, how controlled the blood sugar is, what are all the comorbidities, and based on that, I'll make a clinical assessment. And most of the times, say if it is an MCD, we may have to use it. So in such scenarios, I'll start with the regular dose, but go for a rapid tapering. So rather than going for a prolonged course. So it is not, we don't have a set protocol like how to use steroid in a patient with diabetes having a non-diabetic kidney disease. What I say is we have to again depend on the overall clinical assessment, the diabetic control status, and the comorbidities of that patient. Now, another thing, we have several alternatives. We know how this rituximab is coming up in almost all the disease, how it is being utilized. Even if you take MCD, we know it's no longer a disease like where we have to depend on steroids. An antibody-mediated disease, and anti-nephrin antibodies are coming to picture. So it's like we have several alternatives now. So first, I'll see whether I can use the steroid in that particular patient. Second, if in my personal choice, I'll go for alternatives, fearing the complication of worsening of the diabetes control. And regarding the alternatives, one of the preferred drug in my clinical practice is rituximab. Of course, we have other drugs like MMF. We can use calcineurin inhibitors. So that is a case-to-case choice. So what the dictum is, and in membranous nephropathy, of course, rituximab is better than the modified Pondicherry regimen where we have to resort to steroid again. So dictum is treat and non-diabetic kidney disease in all cases possible to avoid endangering or avoid progression of the renal failure. Second thing, use steroid according to the diabetic control and the comorbidities, like how to start, what dose to start, how rapidly to taper. Everything depends on all these questions. And third thing is regarding the alternatives. So for me, the preferred one is rituximab, but again, based on the clinical condition, it can vary. And regarding the second question, does IgA nephropathy behave differently in diabetic patients? Of course, yes. As I already mentioned, a combination of a non-diabetic kidney disease with a diabetic kidney disease is a worst scenario you can have. And it is not just for IgA nephropathy. It's not just for glomerular disease. Even in case of a non-glomerular kidney disease, in combination with diabetic kidney disease, it has a worse prognosis. Say take ADPKD. ADPKD, we know it's progress very slowly only, but if it is happening along with the diabetic kidney disease, the progression rate is faster. So definitely IgA nephropathy, the course will be different in a patient with diabetic kidney disease. And to slow this progression, again, we have to have an aggressive approach. Use all the pillars of the proteinuria lowering therapy. And we know how beneficial this SGLT2 inhibitors are now in IgA nephropathy. Use it. RAS blockers, also the mineralocorticoid receptor antagonists, and the general measures like of a tight control of diabetes and blood pressure control especially, and weight management along with other lifestyle modification.
Right. I would just want to highlight, because I've seen two patients. One was a donor who had presented recently, just 6 months ago. She had donated around in 2012, and she developed nephrotic range proteinuria, and she had anasarca, and incidentally also was found to have diabetes. In 2012, when she donated, there was no diabetes. And in 2025, she turned out to be a diabetic. She developed 6 grams of proteinuria, and there was no diabetic retinopathy. In this case, we did a very high risk biopsy, and she was found to have membranous nephropathy, which was plateau positive. And why this question came up is because we did not give Ritux. We gave a modified Ponticelli, which was MMF and this thing, what do you call it, cyclophosphamide. And what we saw that in the second cycle, she developed neutropenia. And we had to stop the Ponticelli regimen and then just go back to what you said, antiproteinuric measures. But in that period, when she was diagnosed to have de novo diabetes, plus she's a donor, plus she has membranous nephropathy, it was very difficult to treat, because even if you give her a pulse steroid, then we had to up her anti-diabetic medicine, put her on insulin, and several other things. So that was a difficult case to manage. So this is why the first question. The second question, IgA nephropathy, we had like a 60-year-old gentleman who had diabetes since 7-8 years. And again, he also had proteinuria. Biopsy showed IgA nephropathy. In this situation, we did not treat him with budesonide, because this is a recent case that has happened. But we also pulsed him. We started him on 60 milligrams. We rapidly tapered him. And then now, after he has some 1 gram, 1.5 grams of proteinuria. Now he's put on budesonide. So the whole premise of these two questions is that only what you have beautifully explained, that steroids, if we are giving in non-diabetic kidney disease, we tend to rapidly taper them. And of course, we should have antiproteinuric measures also. And I think maybe we should think of giving rituximab in this donor, because she's recently developed leukopenia. So I think that would be a good head start in her case. The next question is for Dr. Christine. we've already had this clinical experience with the use of 4 antiproteinuric agents, that is SGLT2 inhibitors, MRAs, ARBs. And so ARBs are there for a very long time, whereas SGLT2 inhibitors and Finrenone is like just there since the past 2-3 years. So I would want to understand your experience on these two molecules more than ACE-ARBs.
Right. So I think Purva, optimal use of these 3 group of drugs in diabetic nephropathy really can work wonders. What I have seen is we have, biopsy proven diabetic nephropathy patients with nephrotic range proteinuria to the tune of 7, 8, 9 grams, coming back to less than 1 gram when they stick on to these therapy, and we are able to achieve the maximal tolerated dose. I think achieving, like you rightly told, ASABs have been forever. But again, how many patients we are able to increase the dose to the maximal tolerated dose? Like we have patients, on Ramipril 35-40 milligrams along with SGLT2 with the Finrenone, and we are able to beautifully control the proteinuria. And once the proteinuria comes below a gram, and the GFR just stabilizes for 4 or 5 years, even if the creat was, let's say, 2.5, GFR of around 45, it just stabilizes. So I think optimal use of these 3 group of drugs, that is ASABs, SGLT2, and Finrenone, can really work wonders when started at the right time. And I think now GLP-1 analogs are also being added into the armamentarium, although the cost is prohibitive. So I don't have experience with GLP-1 receptor analogs, which some people consider as the 4th pillar of therapy. But ASABs, SGLT2, and mineralocorticoid receptor antagonist put together, when given an optimal dose, when continued, along with Dr. Jyoti Priya has stressed upon other optimization of lifestyle, blood pressure control, smoking cessation, all these are important, weight management. But when given these 3 group of drugs continued without, sometimes patients get panicky when the creat is going up, when you increase the dose of ASABs, or one episode of fever and the creat goes up, they stop the drug. So this is very common in practice, because patients say that I had come to reduce my creatinine, and after you started something, the creat has gone up. So it becomes very important, I think, in our practice to explain to the patient, spend that time, especially when we see for the first time, that it is the proteinuria which we have to control. And we are going to do it with medicines which are going to reduce the filtration pressure, will increase your creatinine, which is part of the treatment. And it's sad to see that many times patients themselves stop these medicines when they see the value of, that number going up by that decimal. They just stop it. And so many of our patients are devoid of the benefit of these drugs. So I think we have to counsel our patients appropriately to make sure they continue on these group of I would say wonderful drugs to provide maximum protection. 4th thing you've mentioned is about vitamin D analogs. So I personally don't have experience of using vitamin D analogs as antiproteinuric therapy. So I think anybody else here can shed light on that. I personally do not have. I mean, of course, I treat vitamin D deficiency. A lot of studies correlating vitamin D deficiency with RAS activation and worsening proteinuria. So whenever a deficiency is detected, I do correct that. Apart from that, I haven't used vitamin D analogs. Yes.
Right. Due to time, I'll just take up the next question, because I would personally want everybody in the panel to answer this, even those who have joined this webinar. Usually patients present to a nephrologist only when they have renal dysfunction. And there are studies now which are trying to focus more and more on early detection of kidney disease, even when it manifests, before it manifests clinically. And we are having the access to biomarkers like HSCRP, TNF-alpha, IL-6, which are routinely being done in India as well. Now, I would want to understand if there is a role of immunosuppression in patients who have diabetes, who do not have any diabetic nephropathy lesions on biopsy, but they have elevated biomarkers. Now, as we all know, elevated biomarkers suggest inflammation. and that inflammation somehow can be non-infectious. And in these scenarios, is immunosuppression justifiable in these cases?
Yes, Purva. So I think going back to the pathophysiology of diabetic nephropathy, we all know that it's a combination of metabolic factors, a lot of inflammatory pathways, antioxidant pathways which get hampered. And of course, there is a significant component of hemodynamic factor, which we try to address by certain drugs. And the inflammatory pathway was unaddressed for a long time. And now we have the mineralocorticoid receptor antagonist, which is addressing the inflammatory pathway. But like you pointed out, in early stages of the pathophysiology of diabetic nephropathy, wherein there is a lot of inflammation going on as a result of the advanced glycation end products and those abnormal changes, it is probably, I think Radhika ma'am would be able to add on to it. My pathophysiology is little rusted, but grossly what I'm trying to say is there are a lot of inflammatory pathways which are activated early on in the pathophysiology of diabetic nephropathy. But whether we are in a position to intervene at that stage of pathogenesis clinically, I mean, in a given patient, whether we are able to alter that course at that stage, I doubt, because these inflammatory markers have been studied in various clinical scenarios, and they have their positives, but also they have a lot of drawbacks. In the sense, there can be a lot of false positives. There can be other coexisting conditions which can lead to elevated inflammatory markers. So I think in the sense, immunosuppressing, use of immunosuppressants anywhere in the pathogenesis or in a given patient with early diabetic nephropathy, I think from what I know and what I've read, it is very primitive. But I would be happy to hear from others.
What is your take on this, Dr. Jyotipriya?
In our clinical practice, this question of whether to immunosuppress the patient without even without any diabetic nephropathy lesion on biopsy, I think at this stage, we
too early
really
to say.
don't, because see, for us, what we see in general is patient ending up with severe infection rather than it's a general practice. What we say, even if the patient is having a non-diabetic kidney disease, we are immunosuppressing the patient. The next thing, patient might have improvement, but subsequently he'll be coming back with some florid infection. So the thing which we fear with immunosuppressants is the infection thing. Now, when we don't have a lesion itself in biopsy, forget even if we have a renal failure, we are not using immunosuppressants in clinical practice to mitigate the effects of all these inflammatory biomarkers. I think we need more research in it, and probably with more studies and research, we'll get more light in this area.
This is the reason why I put this question, is because this is pretty this is in the nascent stages. We don't know. But
Yes.
the diabetes, every year or every 6 months, there's something new. And the more you know about its pathology, the more treatment options are, getting crystal clear and things like that. So I think we've
I
come
would like to ask one question to all you nephrologists. Like, how often it occurs in your practice that first time the patient comes to know he or she is having diabetic retinopathy and simultaneously nephropathy? Like, how many
out of
patients?
10 patients, I think 5 probably will definitely have diabetic retinopathy.
No, I mean, they
And
come
they
to know
reach
that it's
us.
like first time
By the time they reach us.
What Radhika madam is asking, like simultaneously finding out retinopathy, nephropathy, and in some cases even diabetes itself, along with all these combinations.
Yes,
We get
yes,
all
like
this wonderful
it's
combination.
all the first time
Yeah.
they are getting to know that, oh, I'm having all these things. Earlier, there was nothing. Like, so
Quite
does
common.
happen? Like, I have read that is like hardly it is 5 to 10% from the literature, but I would like to ask you.
It depends on the socioeconomic status and the awareness, the crowd we are dealing with. Because nowadays, what I'm seeing is people are so much aware because of the social media spread and all those awareness thing. They are checking periodically, having health checkup, and they are picking up things much earlier than it was 20 years back. So I think things are changing, but again, depending on the socioeconomic status and the awareness level of the crowd or the patient population you are dealing with. So this may vary with that.
I'll just like to add one more thing. So I agree with Dr. Jyotipriya. It depends a lot on what socioeconomic strata of patients you're dealing with. But another interesting thing we are finding, in Bangalore, I mean, I was really surprised to see that the so-called IT capital, we are seeing many young IT professionals diagnosed with diabetes very early on, like probably in their late 20s, early 30s, they are being diagnosed as type 2 diabetes. And they're put on medicines. No, so now they have this, burden of lifelong medicine. So then they take it for probably a couple of months, and then they just stop it. They try out, everything else, healthy lifestyle, or some, they join some app or some group. They try out all X and Y things. They stop the medicines altogether. And they land up directly in a CKD stage, advanced CKD. We have seen patients, so-called educated patients, in denial, because they cannot handle that burden of being diagnosed with a chronic disease, which is there for life. So it's quite disheartening to see that when early stage interventions are so effective in really retarding the progression and halting the disease, we see young people landing up in ESRD in their late 30s because of diabetes, or even in their mid 30s. I mean, that's a very
sad thing. Actually, what I have felt is it's mainly because the age gives an extra confidence for the youth. Because for me, I am practicing in an area where there is predominantly geriatric population. So daily I'm seeing patients 70 plus, 80 plus, even 95, 97 coming regularly for follow-up. So I think as the age advances, that we feel like we need to be more careful about our health. But young patient, it's very difficult. As rightly Dr. Christine told, it's not about Bangalore. I think it's in general, it's very difficult to treat youth with chronic condition, especially diabetes, hypertension, because they feel very healthy otherwise. So they feel there is no need for all these medications and follow-up, because they can lead a normal life otherwise also. So why unnecessary pill burden and all those things? So basically, it's a very crucial thing, the counseling and making them aware and sticking on to therapy. That is tremendously, it's a tedious work. And of course, if people are following app and reducing the weight or lifestyle, I think that's one extra thing which we have to appreciate, Dr. Christine, because what in my population is complete abandon, like completely they'll neglect, they have a part of disease like that. So something they're doing.
The problem is they stop all medicines. First thing they do is stop all medicines. Then they don't check. They think that, as you rightly told, they feel healthy, because the complications don't give any symptoms, especially the renal complications are completely silent. So that's the problem.
Right. So we have very senior nephrologists also who are there in the meet. I can see the Rishi sir, I can see Muthu ma'am, I can see Praveen sir also. So do you guys have any questions, or do you have any pearls of medicine which can help us understand non-diabetic kidney disease?
Hi Purva, Dr. Rishi here. Can I speak?
Yes, sir.
So congratulations, it was a good session today.
Yeah,
this has always been a vexing problem, but I think all the panel participants have discussed the issue at good length. It is going to be a patient-specific treatment using steroids in patients with underlying diabetes. It's never going to be an easy answer. But I think till we get better drugs, we will have to use steroids under clinical supervision. And I think there's no real final word that can be spoken about it for today. At least that's what I feel.
Yes. Thank you so much. Are there any questions in the chat box? None. There's nothing on the YouTube live also. So thank you so much. Thank you, Dr. Radhika ma'am, Dr. Jyotipriya, Dr. Christine. And we've had a wonderful discussion. The reason why I would want to have another discussion on diabetic kidney disease, probably 2 more discussions wherein we have an endocrinologist also on board, would definitely help, understand pathogenesis and the early aspect of diabetic kidney disease better. So I hope to see you all again probably when we have a diabetic kidney disease session. And it was a wonderful discussion. So thank you so much for being here
Thank
tonight.
you. Thank you.
Thank you, Dr. Purva. Thank you.
Thank you, dear panelists,
care.
madam. Thank you.
Thank you, Dr. Aditi. Thank you. Bye.
Thank you.
Bye.